All right, welcome everyone. Thank you so much for joining us today for this webinar. We have right now 28 participants joining us, and we're hoping to receive more in the next few minutes. My name is Cristina Navarrete. I'm part of the Innovations Labs team, and I'm working on the Social Enterprise Innovations program. I particularly focus on the learning activities that we do for social enterprises and for policymakers as well. And one of the activities is the online course that we have. So today, this is the first of the webinar that we're having as part of a series of webinars that we're doing in the context of an online facilitated e-learning course that we have. This online global e-learning course this time is focusing on social enterprises, and Adarsh will be one of the speakers today, will be explaining a bit more about who we have in this e-learning course. With this, I would like to introduce the two panelists and the two speakers that we have today. So on my right, I have Adarsh Desai, who leads the Innovation Labs program here at the World Bank. He oversees and guides all of the work that we do in the Innovation Labs, including OpenEd partnership, including a program of big data analytics, and also the social enterprise innovations. I've been working with Adarsh for the last 3 years, and not only because he's my boss, I'm going to say this, but he's truly an expert on ICT innovation and has a passion for everything related with online learning. So it's a pleasure to have Adarsh here today. And the second speaker that we have is Elaine Tinsley. Elaine has been leading a lot of the knowledge work that we've been doing as part of the Social Enterprise Program, and today she will be presenting part of this research. She has long experience working here at the World Bank, over 15 years experience on research, working on multi-sectoral approaches, and also working on the economics, on the rationale of a lot of the work that we did here at the World Bank. So thank you again. I'm really excited to see right now 32 people joining us today. I'll be the moderator for the session, and without further ado, I'll give the word to Adarsh to introduce a bit more the work that we're doing in the Innovation Labs, as well as part of this initiative on bringing knowledge around the business models. Thank you.
Thanks, Christina, and welcome everyone. Good morning, good afternoon, good evening, depending on where you are. Very many thanks for joining this webinar. Christina mentioned, one of the areas in the Innovation Labs here, we focus on around how can we bridge the service delivery gap, especially to the poorest of the population, by helping and scaling some of the social enterprises and the delivery models that many of you have championed in the client countries. As we all know, there is a significant number of population, especially the bottom 20%, that remains unreached for basic services like healthcare, like education, clean water or sanitation, and so on. And we believe that the innovations that have been championed and created by many of you and people like you and the social enterprises all over the world can play an important role in bridging that service delivery gap. And therefore, we are trying to work with the rest of the World Bank Group as well as other partners and saying, how can we look at a broader ecosystem around social enterprises so that the social enterprises as a community, as an institution, can grow and thrive. So we're doing a number of things in that space. One of the things is directly working with the social enterprises, especially around their own capacity building. As we've learned over past many years of experience in India and other countries, that many of you face some common challenges when it comes to growth and scale, whether it's capacity, whether it's financing, whether it's ability to work with the policymakers, and so on. And we've kind of distilled that lesson, if you will, and packaged it as an e-learning program so that we can reach many, many of you over a period of time. So this particular e-learning course that Christina just mentioned is around targeting specifically around social entrepreneurs and enterprises that are tackling problems around healthcare. This webinar is kind of associated with that course, but of course it is open to also others who might not be participating in the course. I have to say that we've had very strong responses around the courses so far, and we continue to do so for even the health edition. We have about 77 organizations, and I'm very happy to see that almost close to half of the participants are women. In today's webinar, so one of the things we've learned over a period of time is that there are many, if you come across entrepreneurs who are trying to address similar problems, whether it's chronic malnutrition or whether it's help addressing some diseases like tuberculosis, etc. And we see that many are struggling or trying to kind of solve the same problem. Of course, their country context, their community context are different, but oftentimes they can benefit from learning from each other in terms of how somebody has already addressed those problems. And we believe that by sharing that knowledge, by sharing that distilled kind of on what the innovation is, how specific enterprises or community have addressed this problem, if we can make that available widely, then it would help many of you kind of accelerate your progress towards kind of tackling some of those challenges. So what we've done is we've looked at number of enterprises across different sectors, health being one of them. Our focus, as I mentioned, is basic services. So health is a key aspect of it. We've looked at about 300 social enterprises across the world, and we've distilled into a handful of business models, if you will. We have about, I guess, 9 business models, that are distilled out of this 300 enterprises.
We have 26 business models.
Yes.
And about 8 within the health sector.
Okay, so we have about 26 total business models, 8 within the health sector, and my colleague Elaine will present 2 of those business models. We intend to make all of this information and data available publicly very soon, but we thought these 2 would be of particular kind of benefit to our audience in the e-learning course, as well as those of you who joined us today may not be participating in the course. We'll share the rest of the models as well. And this is a learning exercise for us as well. So we want to learn from you. So many of the questions that you might prompt today or might share with us later would help us also kind of dig deeper and kind of come back to you with some of the knowledge and some of the things we've learned. So we don't promise that we'll have answers to everything you ask, but we certainly would take that to heart and try our best to look at kind of the global knowledge around this topic and at a later date come back to you. So please ask as many questions as you can. I know we have only an hour, so we might not be able to reach or address all of those questions. But nonetheless, those are very, very important because we are doing this in service of your goals and of your initiatives and of our collective goal of addressing kind of extreme poverty. So very excited to be here. Very excited to see that the participant list is growing. We have about 45 already on this webinar, and without taking much of your time now, I'm going to pass on to Elaine. And look forward to engaging with you through the course and through future webinars around this and other topics. So thank you for being with us.
Hi, my name is Elaine, and I've been with the Social Enterprise Program for about a year now, and part of my main role in this program is to build our knowledge base and our knowledge of social enterprises. And one of the first things we realized is, there's a lot of social enterprises out there. There's a lot of different experience. A lot of it's very rich. And ideas like, how can we actually help scale up this sector? How can we help scale up these social enterprises? And for a while, we were part of the development marketplace, and the idea was that we would offer grants to social enterprises. But the feeling was that more needed to be done to actually have a greater impact, because a lot of these social enterprises are having great impact on the ground. And we needed to find out what it is, what are the constraints, what are the challenges that we can help to address to make the working environment and the business environment a lot smoother. So one of the first steps that we decided to do was to build our knowledge base. And part of that is to look to, as Adarsh mentioned, was to scan the social enterprises that are on the ground that have been successful. So like you mentioned, we looked over 4,000 different social enterprises, of which 2,000 were in service delivery, because that's the main focus of the World Bank is actually on alleviating poverty. And so we're focusing more on the service delivery aspects within health, water, and sanitation, education, and energy. And then the idea was that so this cohort we're mainly focusing on health. And by looking through the social enterprises, we identified about 240 that were of 240 that we could like kind of classify into different business models. Because to understand one social enterprise is not sufficient to understand a whole bunch of social enterprises. So each business model is based on about 10 to 15 different enterprises, and we're trying to synthesize their experiences, synthesize their challenges, so that it makes it a little bit more easier to talk about one model rather than one particular enterprise, which people might not relate to as well as when you talk to a whole sector of enterprises. So in our models, we identified 8 in health, telemedicine, mHealth, specialized hospitals, Fortified Foods for, especially for children, for infants, micro health insurance, women's health clinics, our health franchises, community health workers, and female hygiene, or sanitary menstrual hygiene management. Oops. Is it not going? Okay. So of these models, we're going to look at 2 in particular. All of these models are actually focused on servicing the bottom of the pyramid or the base of the pyramid, because we feel like these are the ones that have been able to penetrate the best into serving the poor. And of those, we're going to focus particularly on community health workers and health franchises. So the first one is health franchises. We actually focus a lot more on like women's health franchises, but overall health franchises are more or less the same, whether it's a women's health franchise or it's a primary care or eye care. And so the franchise network is pretty much similar to what a commercial franchise is. It's a social franchise, which with private providers providing the services that normally like the public sector would. So they're providing quality health services based on conventional commercial franchising models. A lot of these focus on standardizing training and monitoring, quality standards and operating procedures, and the idea is to actually build a trusted brand that others can go to. Like in Kenya, you have Tunza, and so this allows them to, like when they go from one clinic to another clinic, to understand that this is the same quality that they can expect, and also to provide the correct financial incentives and be reliable, so that people have a reliable set of services that they can trust on. So this is the model that we're looking at. Again, you start with the social enterprise. A lot of times these are funded by, it could be like an MSI or an international international NGO, and they've developed the tools and the framework and the management for these enterprises. So they grant a license, and they also provide a lot of training. The training is actually quite key in order to provide a trusted brand. And it is actually because they have a trusted brand and they're actually focused on client services that people find these services more, or willing to go to these private providers more so than to like the public sector, whereas the private sector is more likely to focus on issues like shortening waiting times, making sure the doctor is there. So there's quality standards that are followed, and there's quality care that can be. A lot of these franchises also employ a lot of innovative techniques. They use ICT to do electronic record keeping, or to conduct surveys, to provide messages, SMS messages for follow-up appointments. So there's a much stronger client-patient relationship than you would find in the public sector. And then another issue is how to make them affordable, so that it costs less. And a lot of these enterprises will use cross-tiered pricing, cross-subsidization, and our vouchers, or they work with the social. I mean, the key thing is if they're able to connect to the national health insurance or to the national health system, so that they're able to provide services. And then the fourth one is being available. Because these are franchises, they can be located in more rural areas and still bring quality care out that far. I think a lot of times people find like public facilities, public clinics that are more rural, it's more difficult to find a doctor that stays staffed there, or if the doctor shows up, they're less sensitive to that client relationship. So this is where, if they're able to build the trust and the quality care, then they're able to maintain and keep the clients. So who are the stakeholders in the franchises? The first are the donors, who provide the funding, the program assistance, the parent organizations, which provide the framework and the training, certification, supervision, and quality assurance. This is quite key because this is where the large overhead happens. So the idea is sort of like McDonald's. So you have a standard of operation where you can have, if you have the fixed costs of developing all the materials, and this can be passed on through the different franchisees, and they just pay a fee for it. There's also the benefit of buying in bulk and being able to pass on forward a lower price. This also helps reduce costs. It also ensures a reliable supply of medical supplies too. You can centralize as much as possible of the management, and then the franchisees are focusing more on the service delivery. And then there's also the employment use of outreach workers to raise awareness, to recruit people. These are people who are familiar with the communities and can reach out, and the idea is to incentivize them enough so that they can make the referrals, they can reach out to the community. And we'll talk a little bit more about community health workers in the next one, in the next model. And the final is the government and policyholders. A lot of it has to do with like accreditation and integration with national systems and demand-side financing. But the government, the more that they can work with the government to provide payments support, that also makes it a lot more feasible and sustainable. And part of all of these models is that we realized is what it takes to actually deliver value for the bottom of the pyramid. And so there's actually 4 aspects that we look at. One is acceptance, awareness, availability, and affordability. So the acceptance is like, what is it? How do you design a product? How do you design a service so that the community is more willing to engage with it and to use it? And so we find that with health franchises, there's a lot more cultural sensitivity. There's a use of female healthcare outreach workers. So you get a better service, a better client interaction, greater willingness to use ICT, and for satisfaction surveys, etc. And then you have awareness. One thing with an awareness is because of the franchisee model, a lot of the fixed costs on like advertising can be done at the center, and this helps with lower the costs. It centralizes the costs, and then also so that the franchisees aren't having to spend a larger portion of their budget on these kind of activities. And these are standardized. Standardization is also a great thing for action on the affordability side. And you also have availability, which is the employment of using outreach workers to increase availability and access. And then finally also affordability, where we talk about the cost subsidies, the tiered pricing, vouchers, and insurance. So overall, that's how health franchises work and how they deliver value for the base of the pyramid. So what impacts and results do we see? In Tanzania and Kenya, they've had over 710,000 visits since 2008. You get improved health, improved access, health franchisees. You can have partial franchisees, so it's not that they're complete duplicates, so they can actually be a little bit tailored to on the ground. They can be both in urban and rural areas. And you have increased community productivity because of improvements in health. And because you have a better relationship on the ground, you're more likely to also have greater patient retention and revisits. So basically the franchises balances market economics, and actually once they are present in the ground, we also find that they're also more able to lead to greater price competitions, and you can see lower costs in services too, as it becomes more competitive. Okay, let me explain a little bit more about the tiered pricing. So the tiered pricing and the cross-subsidization, I'm picking up some of these questions. The camera is actually in the way of the questions, so I can't quite see the questions all that well. But the tiered pricing is where you have different price levels for different services. So let's say like if you're doing maternal health care, if you get your own room, then maybe you can have a higher price for that than you do for a room that's shared. There's other examples of tiered pricing too, but I'll come back to that too. So. Okay. So the second model that we're looking at is the community health workers. And community health workers are probably the most overused people in the world. I know in India they get used for doing so many different. They promote health education. They promote. They facilitate a lot of follow-ups. And so it's actually really important that they get trained well because they are the ones who are the closest interaction with the communities. And they are the ones who refer the patients to the health facilities. And one way that, but they also have a high attrition rate because they also do a lot of work. And going house to house, talking to different patients actually is very time consuming. One of the key innovations that has happened is for them to actually begin selling health products and other goods to help supplement their income so that it makes it more financially viable for them. And so, let's see. But they are quite an integral part. So what happens is that you have, for the community health workers, let me go forward a little bit. When you look at the different people involved, So the community health workers are mainly members of the rural low-income communities, and they're not professional. Sometimes they're not even literate, but with a lot of new technology these days, they can actually be able to do a lot of the basic care and treatment. And they also are a vital part of collecting data. So their role is actually quite comprehensive in all the different roles that they can play within the health system. Actually, when you combine community healthcare workers with ICT, you really widen the whole expansion of being able to collect data on what is happening within the community, being able to follow up on treatments. You're also able to be a little bit more culturally sensitive. A lot of these ICT tablets that the community health workers can use can be adapted to be more culturally sensitive. They will actually give feedback on how to tailor the material so that it is a little bit more acceptable. And they also are the distributors. They are the distributors of health products. They can be the distributors of mosquitoes net, where otherwise it would be very difficult to get these things out to the communities. These community health workers are able to go out there and do that. So they actually play a very key, vital role. Okay. So you have, so I think we covered how they use ICT for mobile to facilitate patient monitoring. We've seen them used to also help with nutrition cases where they're able to go out and do follow-up on families with malnourished children to make sure that they get sent back to the feeding centers if need be. It's the cheapest way to actually do follow-up services, and it doesn't require such high skills to be able to be community health workers. But the idea is that to keep in mind that community health workers actually need to be incentivized and to not realize that, just because they're on the low income spectrum, that they shouldn't be squeezed. And I think we're seeing increasing models where they are actually trying to empower the community health workers by giving them supplements to help enhance their livelihoods, and it gives them more professional dignity in their work too. So the 4 A's of delivering value through community health workers is the for acceptance is to localize cultural contexts and language. A lot of times things they'll adapt for the dialect. And also it helps address youth unemployment because a lot of these community health workers, they can be young girls or they'll be who it gives them their first professional step in. They also are very key on raising awareness and creating demand for services. And they reach their communities. They can do door-to-door, they can do kiosk-based services. But the idea is that they are very approachable and they are a very easy way to get into the communities. So the impact and results is actually quite high, especially when you combine it with ICT technology. to be able to manage how they access the communities, how they kind of are able to track the patients. And they can actually, here's the case where, you know, because they were also distributors of goods, they were actually able to reduce the price of anti-malarial drugs, for example. And there was also a reduction in counterfeit drug sales because they could also provide, because they had that face one-on-one interaction, that gives them a lot of leverage to make sure that what they're providing is a quality good, because then there is a face behind who's selling that product. And so that reduces counterfeits and improves quality of care. So as to other models that we've looked at too, we're going to kind of generalize some of them on how the different aspects of different models. One is product-related business models. So on the female hygiene and sanitary products, this is actually a key issue for keeping girls educated. In some countries, it's 1 out of 4 girls drops out of school before they, because they get their period and then they're too embarrassed to go to school, or their parents, or they have to end up staying at home. So actually the introduction of sanitary products into their lives can actually make a big difference. It allows them to attend school without embarrassment. But the problem is 3 things, right? One is awareness and behavior change. A lot of times people will pay for diapers, but they don't pay for sanitary products because they don't realize the value of having sanitary products is the reduction in infections and the reduction in urinary tract and other reproductive tract problems that can happen later down the line. So how do you create the awareness? And we've seen, like, a lot of these social enterprises that are making sanitary products, they have a twofold approach to it. One is the distribution and the making of the product, and the other one is actually the awareness aspect of it. Because you need both in order for it to be sustainable. So I think once people are aware of the importance of it, then the behavior change can take place. And then the idea is then you also have to address the issue of affordability. How do you lower the prices? A lot of times they'll do decentralized production of sanitary pads. It'll be done by women in the community that can be distributed. There's a lot of equipment there from different organizations like ACA Innovation. They provide equipment, and then the women, and they also provide the supplies. So that's their revenue stream, is to provide the supplies, which are based on actually local inputs. And then the women's collectives or the schools can actually make the pads and sell it around, and they can sell them quite cheaply. So you have community distribution, you have awareness and demand, and then you have finally the female consumer who can benefit from it. So, and actually though, I mean, I think menstrual hygiene management is actually one of the most, it's one of the more taboo topics, but it's actually one of the most critical health leverages that if there is more awareness around it, can actually make great inroads. Because the problem is when girls are dropping out of school, and in Kenya, they miss about 1.5 months of schooling each year due to their periods. This really enlarges the gap in education outcomes between them and boys, and that just like sets them up even further in life. So the more this can be addressed and more it can be promoted, it's actually quite good. So another product-related business model is that for Fortified Foods. And unlike for the sanitary pads where you have a lot of decentralized distribution, for fortified food it actually makes sense to have more centralized production, because that can actually help lower costs more effectively. On the ones that we've seen where they're making yogurt, you need a large yogurt company where it's much easier to have one large company that produces a lot. And then you have a distribution network, which is based on ladies selling it out. There's a lot of R&D that needs to take place too. In cases where there is fortified food that can be produced decentralized, then by all means, then that is a means. But I think the fortified food models that we've seen are mainly need to have more centralized distribution, centralized production, and then you have the decentralized distribution efforts. And we've seen great results for fortified foods too. And then the idea is also, you also need the awareness and the marketing. And that is something that, you know, if you have that is something that actually can be joined with the government to promote and campaigns for increased nutrition. So in a lot of these models, we kind of don't really touch upon the role that government can play. But as the World Bank, as one of our key counterparts is the government, and we're always looking for means of like how it is that the government can support these enterprises, maybe not directly, but maybe through more information campaigns or maybe through policy changes that are more effective. So we're also interested in hearing some of your experiences on like what are the policy challenges that you guys face that, you know, if addressed would greatly help your businesses to succeed. So we're open to suggestions. Another model that we looked at was specialized hospitals, where we're looking at service-related models. And in this case, for the example, this is quality eye care. It could also be for diabetes, where you have a hub. So it's a hub and spoke model, where you'll have the secondary eye care, the main tertiary center, which is has in the major cities and has the staff training. It develops the standards of procedures. Then you have the secondary eye care clinics, and then you have the primary eye care clinics, which go further and further out. And then you have the rural outreach activities, which are the mobile units or the road shows and the free eye screening. So these are the ones that have little mobile vans, or even we've seen ones where it's with motorcycles. And then these are the ones, this is how you get further and further to the last mile. And then the idea is to make the whole issue here with like specialized hospital is to do affordability. And one of the ways that they also do that is through standardization and also tiered pricing. And then they do the accessibility. So getting to the last mile is always like the most expensive aspect of it. So there's always challenges to like how it is that you can make this last mile more affordable. And we'll discuss actually some of that a little bit later when we look at different strategies to reduce costs. And finally, the last group of models that we're looking at is the financial planning related business model. And this is where for like micro health insurance. This one actually involves where you have to actually involve a whole slew of partners. So you have consumers, you have the micro health insurance, you have consumer education, which is quite vital. You need to have efficient process because the margins are really difficult. Basically you're selling a product to the poor for something that they may or may not receive. So it's the whole aspect of insurance where, they're giving money and it's for a risk. And so this takes a lot more, I think, management in terms of making it more appealing. But then it's also how you educate the consumer to the benefits of it. And then the key thing is to like also tie it into the health network system. So it's actually a very multi-partner program, and then you can also have technology to help bring in the mobile technology to help reduce the costs. So after looking at all these models, so we looked at 260 different models across the different service sectors. Some of the strategies, there's two key aspects that we're going to focus on now. One is awareness, and the other one is affordability. Because awareness is what generates the demand for your products and your services. And so some of the strategies that come are from educating consumers, recommendations from influential individuals, whereas it could either be like the village head or it could be a woman in the women's health group that's very influential and gets well respected. Another way is to make the product more aspirational, like sanitary pads. A lot of ways that they're selling it is promoting it is by showing that this is a nice, clean way, it's a clean feeling, so that to get uptake on it. And product demonstration and experience. So people can actually, through events, they can actually see what the product does, see the benefits from it, and they're more likely to adopt it then. Another way to raise awareness is by bundling it with more familiar brands. For example, this is what they usually do with health insurance. If you get a microloan, then the idea is, they kind of tie it in with health insurance so that you can see the benefits of like, once you're familiar with it and can use it, then you're more likely to continue to do it. And then another strategy is to have an initial subsidy or a voucher that can encourage it. Like you can give vouchers for vaccinations, and then people will come and say, okay, when you go back to the village, here's two vouchers for vaccinations. That will encourage people to take up on it if they also see that it's being given to them by someone that they trust. Other ways of doing other means of doing this by conventional advertising, like we found for the health franchises, and partnering with government and NGO campaigns, and also through the distributors, which is the one-on-one with the community health workers, or other distributors too. These are actually strategies that to raise awareness that cut across all the different models in all the different sectors. So it's not just specifically for health. And then we also have cross-cutting strategies on affordability. One of the key issues is costs are too high for low income. Willingness to pay is hard to determine. Even if they are willing to pay, sometimes it's irregular and constrained cash flows. And then it's also high distribution costs to the last mile. And then we've kind of lumped the two different strategies into reducing the product cost and assisting with payment. But it's not, we'll go into more detail. So how do you reduce costs? So this is really on the upfront side, right? One is that you can redesign the business model where, like for Jacaranda, what they did is instead of having, they had the nurses provide all the clinical care, and then community health care workers manage the home visits and the client education. So they really kind of did a lot of task shifting so that only high value work was done by high value, high skilled people, and they left the grunt work to the lower skilled. Using ICT and technology, for telemedicine, for example, they're able to have quality service of a doctor, access to a doctor, without having the doctor travel, which takes up a lot of time and is very expensive. So by using ICT, and I mean, ICT can also be used for like training purposes too, which cuts down a lot on the costs associated with like face-to-face training. It might not be as high, but it's actually, can be quite effective in being able to scale. Another key way of reducing costs is standardization. And I think this is particularly true within the franchise models, but actually across all the different business models, the quicker they're able to standardize their business process, or the quicker they're able to, it's also standardizing business process, but it's also standardizing the service that you provide. So in this example, for example, if it's a complicated cost, they will shoot it out. I know Jacaranda does this, and LifeSpring Maternity also does it. If they know this is going to be a complicated cost, rather than then trying to do it, they will push it on to the hospitals, and they're quickly referred to the hospitals so that they can get the quality care without the clinics themselves having to have that kind of skill level to operate. Next one is shared access, where you do equipment sharing. So each clinic has an own day for equipment, and so for a dialysis machine, sometimes it's easier, like if on Monday you know it's located here, on Tuesday it's located there. It doesn't all have to be within the same franchisee network, it can just be different clinics. Another way to reduce costs is by self-delivery or volunteers. This is more like if it's a product rather than a service, I guess. And another way to reduce costs is actually increasing the value for the customers by increasing the benefits that they get from the products. So like if you're doing insurance, microinsurance, you can increase the benefits by offering subsidized mosquito nets, which actually helps the insurance because then you don't have to do the outlays for any treatments for malaria, but then and the consumer also gets the cheap mosquito nets. Another way to reduce costs is sharing costs is with third parties. So if governments or NGOs are interested in particular outcomes, they can come in and work on the fixed costs. Let's see. On the cost-cutting strategies for affordability, so this is on payment assistance. So what is it that can be done to help the customers pay for it? And a lot of times you'll see like cross-subsidization, which is the tiered pricing. So charging more to one set of customers and less to another, and then this allows them to pay. We see this like a lot with like Arvin Eye Care, I think is one of the biggest examples where they're able to, they have such a set of standardized procedures, but they can offer, charge the higher income clientele, and they actually have clientele coming from overseas to get their cataracts taken care of, and with the money that they make, they're able to provide pretty much free services to the poor. Vouchers and subsidies, I think that one's explanatory. And then matching cash flow. A lot of times people can't afford that large lump sum, but if they do payment by installations, that's helpful. are paid by use, or small servings, like instead of a whole packet of sanitary pads, you have a packet of 3 or 4. And then also flexible terms. And finally, another way is through consumer financing. There was an interesting model where people in Latin America, where they would actually prepay for delivery, so it created a culture of kind of like saving towards it. And then this way, it wasn't a huge lump sum payment for when they had went into delivery, but it was actually paid over time. So these are just some of the assistance mechanisms. And finally, we have using ICT solution. Oh, I see we're running a little bit short on time, so I think I covered a lot of the ICT solutions on service delivery. Besides training, and then access to information, we have training, data collection, dissemination, payments. You have mobile money and payments over time or by other parties, and then analytics. I think that's the one we probably haven't tracked as much, is how we can do stock management, tracking supply chains, and surveys and feedbacks. And here are just more examples of how ICT has been used in health interventions. I think the only one we didn't really touch upon is the emergency medical response systems. There's a lot of interesting models out there, including like a Uber-type model where people can act as ambulance services. They get basic training, and then there's a whole system in place for to access these transporters to take them to the hospital, so they're not waiting 2 hours in traffic for the ambulance to come out and get them, if there is an ambulance. Okay, and the last thing we just wanted to touch upon really quickly was just the scaling up models. This is more framework. We're going to be doing another webinar session on replication and readiness for scale. But kind of just to have the framework in mind for when you're looking at scaling up or replication, to look at it between a closed approach versus an open approach, where you go from a branch to a franchise to a partnership to a joint venture, or you have an open model and then you have a second mover to it. But that's just actually just to touch on it a little bit lightly for things to come in the future. So, okay. So that's it. Thank you.
Excellent. Thank you so much, Elaine. This has been such a wonderful presentation and also very rich. I actually quite learned a lot. I know some of you are having some issues with the connectivity, so I'll just remind you, this is being recorded and is going to be shared with you within the next 24 hours in the Institute website, and also for the e-learning participants, we're gonna post it in the platform that we have. So no worries if you have any connection difficulties, you'll be able to see the entire presentation afterwards. So I'm quite thrilled to see all the interactions that are going on the chat, to see that some of you are already exchanging emails and answering as you go several questions that have been raised. I've been collecting some of these, but before I go into the questions of the participants, I would like to ask Elaine, how can people access this information? I know this is something that Adarsh mentioned, that we're planning on sharing this, but today we presented only 2 of these BMIs, business model innovations, in detail. If people are interested in going deeper into those, maybe sharing some of the challenges, as you mentioned, regarding how they're working with policies, what are some of the environment challenges that they're facing, how can they access this information, or when is it that they're going to be having access to all this knowledge?
Our website is actually in the process of being produced, so hopefully we will have all this information up probably by mid-February. But we're actually happy to share it informally offline too. I'm looking at our program lead and she's like, no. No, but I mean, we're happy to discuss it more in detail. I mean, the World Bank is very open on its information and things. We just need to kind of vet the information that we're doing a little bit. But we're always more than happy to talk more about the challenges. I mean, this was really a skimming of the top of the information that we have, and I think it's...
I'll jump in.
Okay.
Sorry, since I was put on the spot. Hi, I'm Natalia Gapitova. I'm the coordinator for the overall program, and very excited about the webinar, actually, to share some stats. We had 52 participants. It's an awesome participation. We're very happy for all your questions. I was tracking online. It looks fantastic. So on this database, I think we would be happy to share the description of the business models informally. It's a draft form, and we're finalizing a number of conclusions. It's not quite settled yet, and that's why there is some hesitation to, send them out before we fine-tune the details. The presentation and key conclusions will be available immediately. And if any of you are interested in commenting, providing feedback for us on the models, we actually would be very grateful for peer reviewers and your suggestions. So send requests, especially if you're interested in particular models you're working on and you would like to give us feedback. We would be happy to share drafts and include your comments in the final versions.
Right. Yeah. I'm noticing also some of the questions on Jacaranda Health. We actually did go visit Jacaranda Health when we were in Kenya the last time, and they have 2 clinics right now. And they learned a lot from opening their first clinic to when they opened up their second clinic. And since they're kind of like in the suburbs of Nairobi, they realized that it actually makes sense to have the obstetric care because that actually makes people more willing to go to them. And I think this is more of an issue because they are in the peri-urban areas, that they have to be competitive in that respect, and then to do that, it actually makes sense. But I think there are still some of the complicated cases that they will push over to the hospitals, but they do deliveries and they do emergency C-sections. But I think it doesn't. If it gets more complicated than that, then I think they hold off on that. But it's actually a very interesting health model, and they actually do a lot of good work. Super. Other questions?
So I'm going to ask you 3 questions that have come throughout the chat. 2 of them relate to the health franchises, and 1 of them relates to the community health workers. The first one that was coming from Scott, who is actually in Zambia today. He was asking us, what is the best way to handle pricing? Seeing in many occasions we have different franchises having different price structures. So you were discussing a lot about pricing, different approaches, different strategies. So can you tell us a bit more about how to handle these differences that they may have across franchises? And I'll ask you a second one related to the health franchises. And this is coming from Julie. And Julie was asking us, in your research, did you come across any local entrepreneur who were actually owning the facilities and operating these facilities, and that could be actually converted into franchising themselves? So a slightly different model than the one that you presented, where it's sort of like the NGO, the mother organization, is providing the facility, is doing the training. In this case, it will be starting by already an existing facilities where they can be converted into a franchise that could be more cost effective. So those 2 questions to start with on the health franchise.
Okay. On the pricing question, I think the key issue is transparency, right? So I know in the United States we have an absolute lack of transparency when it comes to health pricing. But I think, and what we saw when we went to see Jacaranda is they actually had the price list right up front in the lobby. So people knew exactly what they were paying for, and they knew the service. And I think it's okay within franchises to have different pricing because the pricing conditions may be different. For the most part, it's probably better to have it similar unless it's justified to be noticeably different. I mean, if it's noticeably different, then there's something that's very wrong about how it's being managed, especially if the economic conditions don't warrant it. Clearly, a clinic that's further away might have more costs associated with it than a clinic that's like within the peri-urban areas. But I think on the pricing, as long as you're transparent about it, then the second thing is you also have to be transparent about the tiered pricing too. So it's not as if you're saying, oh, you're a rich customer, we're going to charge you X amount. No, the idea is to say, if you want your own single bedroom, this is the price for it. And if you want a shared room, this is the price for it. So that people can see the value for money that they're getting for the different price levels. And I think that's generally what has helped work a lot too. And the second question is on, do local owners want to become part of franchisees? And I think you can see that happening. Actually, that does happen quite often because, especially if it's a good brand name, then it helps them to kind of standardize their training, standardize their offerings. But it's up to the business owner, right? They have to see value in the fact that maybe they will be getting, if the increase in demand that they get offsets maybe the reduction in payments and profits that they make. And this is a call that they have to make. So it is, I think, on an individual case by case. I mean, if you have a successful clinic, and a lot of times it's actually not the brand that might matter as much as the relationships that they have with the community. So if a clinic already has good relationships with the community, then having that additional branding doesn't necessarily mean that they're going to do better. I think it's when they're starting up or when they haven't been very successful in maintaining quality care, and people have kind of been turned off by that. By coming into a branded name and following the branded model, then they're able to kind of have a much more successful enterprise. So I hope that answers your question. Okay. Yeah, I mean, actually, okay, I see your question, Julie. That it's about converting an existing business, but about franchising a successful clinic. I mean, you can't, it has to be the clinic, making the clinic owner the franchisor. Oh, where the clinic owner becomes the franchisor and opens up their other clinics. I think that happens a lot too. I think when one of our participants, Harish is on the line, and he actually had a whole set of clinics that, you know, you start off and then you kind of build it out. So it is possible. And it's usually that first clinic that takes a lot of upfront work to be able to standardize the procedure. And we see that through all the different business models too, right? Once you can develop a good system and a good practice, and you have good standards of operating procedures, SOPs, then you're able to roll it out much more easily the second and third and fourth time around. So, and I think pretty much a lot of the franchisees, not a lot of the franchisees, a lot of them started off with NGOs, but you do get franchisees, health franchisees that have done that, and I can look into it a little bit more carefully and let you know which one it is. But there are a few. This is the best way to make payroll.
Thanks for clarifying that. So another other question that was coming from Swami is in terms of, he was saying that a lot of the challenges, you mentioned a lot ICT, you mentioned a lot the necessity of trained like health workers that are at the front line. What would be your experience to avoid some of the challenges that happen when training these community workers and really bringing them up to speed into some of the day-to-day work that they have to do? They were presenting this as some of the challenges that sometimes they present while trying to train these local communities that sometimes, as you say, are illiterate.
Yeah.
So that's one of the questions. And the second question, I'll just pick straight from the window chat right now is, and I think you touch upon this, is regarding the awareness and some of the things that you mentioned during your presentation is what is the best way to make payable maternal health services work even for free in low-income communities? So those two questions for now, and please keep asking questions as you go.
Okay. I think on the community health workers, one of the key things is actually that leads to a lot of attrition is actually the fact that they're not so incentivized. And I think once they have the proper incentive framework there, and then the issue is, you know, can you train them? Because I think if it's not worth their time, training them is not going to really help much. Because they still have to have a strong enough incentive. And so once there's a strong enough incentive there, then the training can be a lot more effective. So assuming that, you know, the incentive structure is there, how do you train it? A lot of it has to be customized. It has to be picked to the dialect. Dimagi is one of the, in India, was actually very successful in training community healthcare workers. They worked very closely to incorporate the community healthcare workers into the training materials so that when the others were trained, they would also know how to, they were more, the uptake on the training would be a lot higher too. So it's not as if, you know, you can develop training material from afar, but it actually has to be an integrated approach, and it has to be involving the community healthcare workers, and then you'll get a lot more on the feedback loop of it. And then the second question, that's tricky on, like, when something is free, how do you start charging for it? The key thing is to add value to it. So If it was free and it was great quality, then no, that's tough. But for the most part, I think it also depends what are the options, right? If you can offer more value for it, if you offer more personal service, if you offer follow-up, and these are things that people can find value for the product, then they're more likely to pay for it. Because, I mean, the government healthcare services, you can have long waiting lines, you can travel. There's also actually a huge cost for people to go access health services. It's an income opportunity lost and also the transport costs lost too. So I think, by addressing those issues, that can also help improve the appeal for them to actually pay to come see, to access those health services. If they realize that, if I'm going to go see a doctor and I know for sure that that doctor is there because I had the text message that confirmed it, whereas if I go to a public hospital, even though it might be for free, but the doctor's not going to be there, and I went there and I wasted a whole day's worth of transport to get there, which one would I choose? I would choose the one which I might have to pay for, but which I know I'm guaranteed to get service for.
So I'll just take one last question from Juan Guzman. And this is a tricky one. I don't know if you'll have an answer for it. But Juan is comparing some of the work that is happening in the agriculture sector with the health sector. And he's saying that regarding affordability, we've seen some innovative approaches in agriculture, microinsurance, such as paying with work. And this is something that has been tested and had quite a relative good success. So in terms of micro health insurance, have you seen any of these innovative payments putting into place, or do you have any examples that you can bring to the table on this?
Not off the top of my head. I think we'd have to dig a little bit deeper into it, and we can get back to you on that one. That one, there's not too many micro health insurance schemes out there, and whether they do it with work, I would be less familiar with that. A lot of it is, the micro health insurance is very community centered. But there might be, and it might be a case where you can actually transfer the knowledge from the agriculture sector into the health sector. So it might be an interesting case study for transference.
Mm-hmm.
I think we have 2 minutes.
Yeah. So I think in the interest of time, we're gonna start wrapping up the webinar. As said, for those who might have joined a bit later, this is being recorded and will be shared both in the Institute website and also on the e-learning platform. Just before we go, I want to ask Elaine, in this sector, in these business models around health, if there is any further research that you would like to do, what would that be? Or what is that learning gap that you feel based on this amazing collection of information that you've been doing and all the research that you've been doing for the last year? What is it that you would like to go deeper into, and you feel there is still quite not sufficient data, sufficient knowledge around?
I think actually the one thing that we feel, and particularly from a World Bank perspective, is a lot of these social enterprises operate very independently of government ties and policies and stuff. And I think, and a lot of times, when we ask them, what government policies can be helpful, they're like, oh, just kind of get the government out of our way. But I think actually if you are to scale, and this is something that we, as our team, we strongly believe in, the government should be a strong partner, and you can actually get more scale that way. So I think it's kind of to understand what are the pathways and what are the means that we can foster this kind of collaboration between social enterprise and the public sector, so that we are able to increase the impact that social enterprise. Because health services, there's so much demand for health services, and government cannot provide it solely by themselves. So I think social enterprises stepping into this space is actually a wonderful thing. But I think we also have to try to find the synergies to bring them closer together.
Thank you. I'm seeing Faith strongly agrees with what you just said. So in the interest of time, I just want to thank everyone for joining us today. I want to thank Elaine for joining, and also Adarsh. You've seen 3 of our faces today, but there is a greater team that is working on this. So again, thank you. I want to thank you also, Zoe, Alessandra, and Iharika, and part of the team that are making possible these webinars to happen, Jao, Chavi, and the e-learning to keep going. before you leave, I will just ask you to fill out a survey that you'll see. And this will greatly help us to improve the webinars that we will be doing, and also to hear more about what you would like to have in these webinars moving forward. So with not much to say, on behalf of the Social Enterprise Innovations team and the Innovation Labs here, thank you so much for joining us today, and I look forward to seeing you in the next webinar.